Eu vou ter o prazer aqui de convidar o professor Gregory Hammer para começar a palestra dele agora à tarde sobre neurotoxicidade dos sedativos na UTI. Professor, please.
Thank you very much. I hope everybody enjoyed lunch. So we spent the morning talking about the chest. So now it's time to move up in the world to the head. It's a very important organ. If you're a neurologist, you think the function of the heart is to pump oxygen to the brain. So probably now your blood is all in your gastrointestinal tract, but we'll see what we can do. So how many of you are very aware of the controversy of the effects of the sedative drugs we're using on human development, about the development of the brain, that these drugs are bad for the brain? Is this something that is talked about in the cardiology community? Because it started in the anesthesia community, and it's a very important topic in pediatric anesthesia, that the anesthetic agents that we use may have adverse effects on the developing brain. But in fact, usually for anesthesia, we're talking about pretty short exposure, whereas in the intensive care unit, we're using drugs that have activity at the same receptors for days or weeks. So if a short exposure might be bad for the brain, we can only imagine what a very long exposure might be like. So I think this is something that we'll be paying more attention to going forward. So the title of this talk is Anesthetic Neurotoxicity, but really it could just as well be, it's intensive care sedation-induced neurotoxicity. Are the drugs that we're using poisoning our patients and impairing their development? So we have a responsibility to our patients, and this is probably typical of what one of these toddlers is thinking, you know, what are you going to do to me? But in fact, obviously, we don't want to cause any harm to our patients. So let's just talk a little bit about the development of the brain. So we know that neurogenesis occurs beginning about 1 month after conception and is a very important process, of course, in the first trimester of pregnancy. And after the first trimester, the neurons begin to migrate and really connect with each other. And so this process where neuronal axons and dendrites coming together to communicate is called synaptogenesis, the formation of new connections, new synapses in the brain. And this is becoming very active at about 20 to 24 weeks of gestational age. And then after the migration and ongoing synaptogenesis, this produces probably trillions of neurons in the brain. And then all the crosstalk and connection through these synapses communicate to neurons which ones are really not necessary, which ones can we eliminate, or this process is called pruning. So now we're going from trillions of neurons in the brain to maybe 100 billion neurons. So it's probably a 10 to 100-fold reduction in the neurons in the brain. And all this depends on neurons communicating with each other. Just like you can imagine, cells in the embryo will migrate to form different tissues and the heart, and you all know all the problems if things don't go perfectly well with regard to the heart. We have a number of malformations. So the cells are somehow communicating with each other to form tissues and then more complex tissues. And the neurons are doing the same thing. They're communicating with each other, and they're forming lots of connections, migrating to different parts of the brain, forming the thalamus, the hypothalamus, the hippocampus, etc. So this process of the neurons communicating with each other is extremely important, and anything that happens that might disrupt this process probably will cause injury. It would be very unusual if we intervened in human development and made things better. Usually the things we do that affect development make things worse. So again, this is an extremely complex process involving trillions of neurons connecting with each other, talking to each other, and it all comes down to these synapses. So what are our drugs doing at these synapses that make these neurons either more excitable or less excitable or anesthetized? There's two important receptors to think about. One of them is the gamma aminobutyric acid, or GABA receptor, and the other one is the NMDA receptor. So the GABA receptor is a system that develops, that has a lot to do with wakefulness, alertness, cognitive activity, thinking, and all of the sedative drugs that we use, with one or two exceptions, act at this receptor. So the inhaled anesthetic agents, benzodiazepines, propofol, barbiturates, etomidate, we don't use chloral hydrate anymore, but all of these drugs, and alcohol in fact, act at the GABA receptor. And what they do is when they bind to the receptor, they make the neuron less excitable. So if all these synapses are forming, and that requires that nerves are talking to each other, the GABA drugs make these communications less. So they're anesthetizing the neurons, essentially. Similarly, the NMDA antagonist acts at glutamate receptors, and the drug has the opposite effect, or when the receptor is bound by a drug, it has the opposite effect. So when the GABA is a depressive receptor, if you will, glutamate is an excitatory receptor. So a drug that binds the NMDA receptor that inhibits it would cause sedation or decreased neuronal activity. So this is the GABA receptor, and the bottom of this cartoon is inside the cell, and up here is outside the cell. And if this is a nerve cell, I know you all remember that there's a negative charge inside this cell membrane, right? Negative or positive? Who thinks there's a negative charge? Who thinks there's a positive charge? Who doesn't remember? Okay, good. We have somebody in the back. So when this nerve cell is going to be depolarized, remember that? There's an action potential, and what happens is this negative charge goes towards zero. So it becomes less negative. So when something activates a receptor and makes the inside of the cell more positive, it's activating the neuron, okay? So what happens with the GABA drugs, or GABAergic drugs, they bind this GABA receptor, and when the receptor is bound, a channel opens here and chloride enters the cell selectively. So it's making the inside of the cell more negative. It's hyperpolarizing the cell. That means it will be more difficult to activate that neuron. So if this is a neuron that has to do with you being awake, and you take a drug that binds to this receptor, it will make it more difficult for you to be awake. So when you've been on call for 2 nights in a row, and you're lying on the couch, you have a lot of GABA activity or antagonist activity. So what would normally wake you up if you take a GABA drug or if you're sleep deprived will not wake you up. So it's suppressing neuronal activity. And similarly with the NMDA receptor, again, the inside of the cell is negatively charged. When a glutamate binds this receptor, it partially depolarizes the cell. Sodium and calcium enter the cell. So it makes the cell easier to depolarize. But ketamine acts to block the receptor. So it's decreasing this excitation. So it's also causing neuronal depression. So GABAergic drugs and NMDA antagonists have a similar effect in the brain. And we could imagine that they reduce the number of synapses, and they sort of reduce the communication that's going on between neurons to form new synapses, okay? So both drugs we would expect would have a significant effect on the developing brain. So it was around 1990 that experiments that took place in rodents showed that when rodents that were in the period where there's a lot of synapse formation, we could call this synaptogenesis, When they're exposed to GABA drugs, their development is impaired, not just for a short period of time, but for a long period of time. So if the experiment involves the rat going through a maze or finding a little table in the water to climb on to get out of the water, their ability is delayed or depressed for weeks and weeks, and maybe even longer, depending on the duration of the exposure. But relatively short-term exposure causes a reduction in cognitive development in rats for relatively prolonged periods of time. It also increases apoptosis, or cell death, in the brain. So here we can see in the brain depicted on the top with a stain that gets dark when cells are dying or having apoptosis, neuronal cell death. You can see that after relatively short exposure to alcohol or ethanol, there's a lot of apoptosis compared to the normal brain on the bottom. And this is just from ethanol exposure during synaptogenesis. So there are other experiments that followed. The first experiment that I just showed you was done in the laboratory of John Olney. And this one is a similar experiment. You can see the increase in apoptosis in the animals that were exposed to these GABA anesthesia drugs. This is Vesna Todorovic, which is who's the chair of anesthesia at Eduardo's Hospital now. So this was around 1999, 2000. And then basically, I'm just going to summarize and say that in the years following, during the early 2000s, there were many, many more experiments with rodents that showed the same thing, using different drugs that activate the GABA receptor. Anesthetic vapors. Eventually, a lot of studies were also done with propofol, so I'll just give you a minute to memorize this slide. But the point is that these are experiments that reproduce the exact same results. So they're all done in mice and rodents. So the question is, how does this apply to humans? So these would be considered preclinical studies since they're done in animals. Question is, do these things apply to humans? And in humans, things are very complicated. If you have anesthesia or the use of sedative drugs in the intensive care unit, we have a lot of variability in the duration, how frequently the drugs are administered, which agents they are. Does ventilation, mechanical ventilation, matter? We know that when newborns are overventilated and their CO2 is low, they're at risk for developing periventricular leukomalacia. So if you're doing an experiment in animals, you can control this, but in babies, of course, there's a lot of things that you cannot control. Again, gender, could there be differences? Oxygen, could oxygen be contributing or protecting? We don't know. So there are many questions that made people wonder if these preclinical experiments in rodents would apply to human babies. And you can imagine when these articles are getting published, it's causing a lot of newspaper articles, and a lot of parents are getting very worried about the effects of anesthesia on their baby, and asking us as anesthesiologists, is this a problem? So my answer was, well, we know from other experiments, I didn't use this language, but from Sunny Anand and Paul Hickey's experiments or data from Boston Children's Hospital in the 80s, that babies that had a very deep opioid-based anesthetic had better outcomes, developmental outcomes, that babies who were lightly anesthetized with isoflurane. So it's an example that actually deeply anesthetizing a baby so that they don't have a lot of sympathetic response to surgical stimulation and pain afterwards seems to protect them in some ways. So, my answer was, well, we give only as much anesthesia as we need so that the baby is asleep and not having a lot of physiologic response to the surgical stimulation. And we don't give anesthesia unless the baby's having surgery. If it's an elective procedure, we could try to delay it This period of rapid synaptogenesis starts, as I said, in utero in the second trimester and goes at least until about age 2 or 3. So this is the period of concern. So if it's just a very elective procedure, we can wait until the baby's 3 years old, great. But most of the procedures, surgeries that we do in infants can't wait, usually. And if we delay the surgery, the outcome will be less. So if it's repairing a cleft lip and we wait till they're 3 years old, the cosmetic product will be a lot worse. So we always have to weigh the risks and benefits. But there was a period of many years where we really had no data, no information we could tell the parents that was very reassuring once these articles became publicized. I think that this anesthetic or sedative neurotoxicity that we see in babies is a spectrum, because we see also in older adults, I don't know, how many of you have a parent that maybe fractured a hip, had general anesthesia, and then they were not themselves for many weeks, or maybe forever? So there's some kind of effect of these agents on the brain, on synapses, on neuronal communication, probably activating certain genes, turning certain switches on and certain switches off. So it's not just a pharmacokinetic effect. In other words, it's not just when the drug is present in a certain concentration. Even when the drug is gone, there are residual effects. And this happens in elderly people too. It's a different manifestation, but when I started really kind of digging into this further, it made me realize how poisonous these drugs are. So they're poisonous in babies, they're poisonous in older people, and this is something that we need to consider with a lot of intellectual curiosity, at least. Okay, so if we fast forward to maybe 10 years from the early studies, we see some longitudinal studies. These are retrospective reviews. So people with big databases, such as the Mayo Clinic, for example, looked at their teenage population and looked at those children who had surgery before the age of 3 to see whether they had some cognitive impairment as a population compared to children who did not have surgery. And they found that after one exposure, the children developed normally and they did not have any cognitive impairment, but children who were exposed to anesthesia multiple times did have slightly lower intelligence. Now, people said, well, maybe it's because the children that are having many surgeries have other factors that are affecting their intellectual development. And that's plausible. So this was somewhat reassuring, but not really convincing. This is another retrospective study which pretty much showed the same thing, that with multiple exposures there was some evidence of cognitive impairment, learning disability, poor school grades, but we don't really know if it's causation or if it's just association. Okay, so now we fast forward to the middle of this decade, and my friend Andrew Davidson planned this study, which was extremely labor intensive, let's say. So he decided to study babies who had hernia repairs. And he had a randomization process. So the babies were randomized either to have general anesthesia, or we can do spinal anesthesia in babies without using general anesthesia. So we bring them into the operating room and basically we're doing a lumbar puncture and we're injecting local anesthetic, and this will make them numb from their abdomen down. And if the surgeon is pretty fast, he could fix 1 or 2 hernias just under spinal anesthesia. So this was about 1,000 babies initially that were randomly assigned in many different countries to get spinal versus general anesthesia. And then the primary outcome of the study was to do sophisticated cognitive studies when they were 5 years old. And the secondary outcome was to do kind of a lower grade study when they were 2 years old. So this whole population of babies was evaluated for their intelligence quotient and other parameters when they're 2, and then again when they're 5. So the first paper came out when these babies were 2, and there was no evidence of any problem with their cognitive development. Remember now, these babies are having hernia surgery. It takes less than 1 hour. So it's a single short anesthetic exposure, and so this was very reassuring. And then just a few months ago, the follow-up study, the follow-up paper was published when these babies were 5 years old, and they found the same thing. So still no problem after 1 short anesthetic at 2 years and at 5 years. So this is very reassuring. There's another study that was published also a couple of years ago, which showed the similar effect. So we have 2 separate studies, both of which were very important studies, I would say, well-conducted studies that showed there's really no injury to the brain with a 1-hour single anesthetic exposure. So what did we know, or what do we know as of this year? That anesthetic agents may cause neurotoxicity in the developing brain. The peak vulnerability is really from the 2nd trimester up to the age of 3, and that we know that at least in the laboratory, these animals have apoptosis and alteration in development of their neuronal structures. And from the data that we have in animals, multiple exposures or prolonged exposures are problematic, but we don't have data in humans yet. We only have the data from a single relatively short exposure. So before the second gas study was published, the FDA came out with a statement that it was a warning saying that repeated or lengthy use, more than 3 hours, of general anesthesia or sedative drugs in children under the age of 3 during the 3rd trimester or afterward may have bad effects on the developing brain. So this also caused a big outcry among parents, of course. We pediatric anesthesiologists responded to the FDA notice, trying to kind of damp things down a little bit, just indicating or emphasizing that the risk-benefit ratio for babies and toddlers has to be evaluated on a case-by-case basis, that there's a risk of not doing anesthesia and delaying the surgery, or having a very minimal anesthetic that also may impair the developing brain. So we tried to put this in perspective. Okay, so again, these 2 major studies, the gas study and the PANDA study, are reassuring, but they only show development after 1 short anesthetic. What about the mechanisms of anesthesia or sedation-induced neurotoxicity? We don't have all the mechanisms worked out, but there are many plausible components to why these drugs may be dangerous and injurious to the developing brain. There's an increase in oxidation markers, so there's probably some oxidative injury that's facilitated by these drugs. There's other signaling activity. There's energetic stress. There's probably epigenetic phenomena where genes are being turned on and off. So the cause of the adverse effect of these GABA and NMDA antagonist drugs is multifactorial. So I think in the future what we need to think about, what about our patients in the intensive care unit who are getting very prolonged exposure? I think we need to be very worried about them. So can we develop sedative drugs that don't activate the GABA receptor or antagonize the NMDA receptor? What about dexmedetomidine? So dexmedetomidine actually has been shown, it's an alpha-2 adrenergic agonist, of course, so it does not affect the GABA receptor or the NMDA receptor. It acts by a completely different mechanism. So the thing that's very encouraging about dexmedetomidine is that it actually protects the brain. So it not only does not cause interference with synapse formation, but when you give animals dexmedetomidine and a drug that acts at the GABA receptor, they actually do better than those that have the same GABA receptor exposure without the dexmedetomidine. So this is a very encouraging thing about dexmedetomidine. And the other class of drugs that we don't think is harmful are the opioids. So I had a very hard time convincing my colleagues in the intensive care unit to stop using midazolam and start using dexmedetomidine. But I won, finally, as I had more publications to kind of back this up. So our initial regimen for mechanically ventilated babies and children is to use opioids and dexmedetomidine as a primary therapy. And then if we either have toxicity from dexmedetomidine as we increase the dose all the way up to 2 micrograms per kilogram per hour, if the heart rate becomes too slow or they develop heart block or the blood pressure is low, then we'll decrease the dose of dexmedetomidine, try to increase the dose of opioid. If the patient is still very agitated and needs more sedation, then we'll give a little dose of a benzodiazepine like lorazepam just as needed. So we call this PRN, as needed. Probably you call it NRP. Maybe you don't have an abbreviation for that. SOS. SOS? Save our ship? Yeah. That's what SOS means in English. Okay, so I will stop there. I think I'm out of time, and just remind ourselves that our first objective is not to harm the patient. And I think we need to understand that nature is the best way, and that whenever we intervene and do procedures or give drugs, there's potential harm to the patient. And I look forward to the development of drugs that are safer for the brain, more drugs like dexmedetomidine that work at different receptor types, or maybe drugs that can be given to protect the brain from the adverse effect of these GABA and NMDA antagonist drugs. So with that, I will stop, and thank you very much for your attention.